Good morning. Everybody hear me? All right. Good to have you all this morning. Welcome to MS Views and News' first MS Symposium in Alabama. My name is Kenneth Davis, and I have, along with my wife, been selected as the coordinators for MS Views and News here in Alabama, and we look forward to coordinating several events going forward. We're so glad you took time to register for the event and to come out this morning. I know some of you might be saying, well, he don't look like he has MS. Well, I don't. My wife does. And through being her caregiver, participating in support groups and other programs, we found that there was a big need for patient education. And that's why we're so excited to be a part of MS Views and News, because they strictly adhere to patient education and bringing those resources to the patients via the internet, web, and programs like this. And with that being said, we have a couple of special guests here today that's actually support group leaders in and around the state. One of them is from Huntsville, and her name is Karen Hislop. And Karen, where are you sitting, please? If you'd come on forward and take just a few. We're going to give her a few minutes to talk about her support group.
Hi, I'm Karen from Therapy Achievements. We're an outpatient occupational, physical, and speech therapy clinic. We've got 2 clinics, and we decided that we were the perfect venue to host the MS support group meetings in Huntsville. And we meet on the 3rd Tuesday of every month from 6 to 8, and we have a really fun group. If you are not on our email reminder list and would like to be, I've got a little sign-up sheet. Just give me your name and your email address, and I'll get you on our list to remind you of when we're meeting. We do educational topics, and we also talk about resources and problems that people are having, and try to help each other through any issues that are coming up with each other. We email each other and try to give each other support. So if you would like to be part of our group, we would really like to have you. Thank you.
Thank you, Karen. Next is my significant other, lovely wife, Susan. Come on up, Susan. She, her and her co-leader, Nancy Mitchell, helped coordinate and run the West Alabama Multiple Sclerosis Support Group. And this is Susan Davis.
I used to be your better half, but I guess I'm not. Hi, I'm Susan Davis, and I'm one of the support group leaders in Tuscaloosa. And we also meet on the 3rd Tuesday of each month from 6 to 8 in the Northport DCH cafeteria. When I was first diagnosed in 1999, my neurologist told me, don't go to one of those support group meetings, they'll depress you. And it was several years after I moved to Tuscaloosa before I would attend one, but I was pleasantly surprised. It wasn't depressing at all. We have a good time, and actually our members that are in wheelchairs and walkers are actually some of our most upbeat members. I tell people that it's good to get in a group with MS, because MS is such a varied disease and everybody is so different that if you get in a group, somebody will have had that symptom and will have answers to a question that you've had. And I also tell people that it's good to have a sense of humor with this disease, because it is such a crazy disease and throws such crazy symptoms. So I encourage everybody to find a support group either in person, or there's a lot of online groups that are also very good. So anyway, once again, I'm Susan Davis, and if you're in the Tuscaloosa area, I'd love to have you. So just meet with me afterward, and I'll get your information. Thank you.
Also with us today is John Radvillas. He's with the Joanne P. LaGanke support group out of Coleman. John, where are you? Here you're standing up right there. I couldn't see him for the lights. He's not going to speak today, but they remember they're online. They do have a Facebook page as well, and they have an excellent group up there in the Coleman area. I want to take a moment and thank our sponsors that helped put this together. First of all is Genzyme, a Santa Fe company, for providing the needing funding to host this program and educational programs like this. We have representatives from the Alabama Mississippi chapter of the National Multiple Sclerosis Society. We'd like to thank the Tanner MS Center for their support and ongoing partnership. And also we have the Social Security Administration out of Birmingham and their help in providing some Social Security disability information and SSI information here today. We also have the UAB Lakeshore Research Collaborative with us. They're doing some good stuff and good research. Please take a moment and look that material over. Their programs are very intensive and beneficial to learning some of the aspects of MS and maybe going forward with some new treatments as well. For those new to our organization, MS Views and News is dedicated to the global collection and distribution of information concerning multiple sclerosis. We provide education, advocacy, and service to empower and enhance the quality of the life of MS community via the internet and live seminars. We do video record our programs as an enduring material for those that live outside the local area, and those can be found on our website, on our YouTube channel, through our website, which you can access through msvn.org. I am so excited to finally have this seminar here today. We've been looking forward to trying to do something like this for about 5 years. And it's through the partnership of MS Views and News that this became available. And this is actually our second event in Alabama, but we are actually using it as our kickoff program for the new expanded areas. At this time, it gives me great pleasure to introduce the founder and president of MS Views and News. After being diagnosed in 1998, Stuart went searching for answers to many questions, just as you did when you found out you had MS. He began his own site called Stu's Views and News, and that's when I first learned about him. Through his vision and determination, this information is now available through various online live programs and such as you're attending today. And to tell you more about himself and his goals with the program, it's my pleasure. Please welcome my friend Stuart Schlossman.
Now, I know that none of you are really here, though, to listen to me, listen to Ken, but I do want to thank Ken. You're all here just for the raffles, right? I knew it. Food and raffles get you every time. And of course, though, we do know that Dr. LaGanke and Dr. Riser are the big draws to get you in here today. I want to thank you all for coming here today. Yes, like Ken mentioned, this is our second time we're doing Birmingham. And yes, we'd love to be back here again next year with your acceptance and saying that you want us to be here, be in Mobile, be in Montgomery, get up to Huntsville, do programs around the entire state is what we want to do. Last year we held 40 programs, which was like, think about it. 40 doesn't really probably sound that much to you, but there's only 52 weeks in a year, and we did 40 programs. All right, we averaged 67 per program, which meant that we had over 2,400 people attending our programs last year. And this was very much needed. People want to see this. Plus, from our YouTube channel that you just heard about, we had over 10,000 people looking at the videos on our YouTube channel as an enduring material. For you yourselves, just because you're here today doesn't mean that you're going to remember everything that happened here today. So you can go back on the video once it's posted online, and you'll know about it because we'll send out an email to everybody that was here today to just tell you the video's up and it's online. We'll give you the link so you can access it. You can show it to your family and friends, whomever you want to have better understanding about multiple sclerosis, let them know about it. Let coworkers know about it if you want them to see what's going on with you or how they may be able to better accept you if they even do know that you have MS. So, again, today's program format, after I get done speaking, I'm going to be introducing the doctors. We're going to have Dr. LaGanke speak first. Then Dr. Riser will speak. Then we're going to take a quick break of about 30 minutes while food is served. All right, after which we're going to get restarted. We're going to do a Q&A. All right, when we're finished with the Q&A, for many of you that know Tracy, she's the occupational therapist from the Tanner Center, and she'll be up here to talk about assistive devices. And then we're going to have a Social Security disability attorney speak with you. And during the Q&A of the Social Security disability attorney, if anybody has any questions about SSI, the lady that you saw outside from the Social Security Administration, she'll be able to answer those questions as well. So we do hope that you all have lots of questions. You hear me with y'all? Where did I get that from? I mean, that's crazy, right? I'm in Florida. I'm even saying that to people in Florida these days. I've been spending too much time in the South, in the deep South. Last year we did 7 programs in the Atlanta area. That was like, how am I talking like this these days? So today we also want to thank our exhibitors of today's program. And exhibiting out in the hallway that you all passed through was Accorda Therapeutics, who makes Ampera. And we have Novartis, and Novartis produces Gilenya. And then we also have Biogen IDEC, who makes a slew of drugs, including Avonex, Tysabri, Tecfidera, and Plegridy. And then we also have Genzyme, a Sanofi company, who's, again, is our title sponsor, but they were out there exhibiting, and they have Aubagio and they have Lemtrada. Lemtrada is the new drug that you all are going to hear about today. Also today we had Mallinckrodt Pharmaceuticals, who is the producer of Acthar Gel, and then we had Teva Neuroscience, who makes Copaxone. Also with us today, we had A&A Healthcare. All right, I don't want to be up here and talk for long, but listen, in addition to the Tanner Center now working with us, we also have the Joan P. LaGanke Center working with us, and we plan on being, as we spread out of Florida, we want to make Alabama our next to second home, all right? And I want to thank you all for being here today. Thank you. So let's get started. Dr. LaGanke, I'm asking you to come on down. Thank you.
First order of business. It's not spiked, I promise. Okay, well, thank you all for coming today, taking hours out of your Saturday and precious time to be here and hopefully become better educated on certain aspects of MS. I really appreciate Stu for asking me to come back again this year. Last year's program, I think, was extremely successful. I go on the video YouTube site as well to hear how my colleagues speak in different aspects and learn things as well. It's a great website, so I encourage you all to look at the website that Stu has out there. So without further ado, because I have a very aggressive topic, so I have to talk about the current agents we have available, about wellness, and about diet, nutrition. I mean, this would be a multiple hour talk if I did it fairly. So I'm going to speed through it and give due time to Dr. Riser for her talk after mine. So first, we need to know what we're dealing with. And some of this is, a couple of these slides are from last year's presentation as well, but I think they're very important. This disease is like a torrent inside the brain and spinal cord. It's like a torrent. So this is a tornado that hit our town a couple of years ago, about an anniversary coming up this next month. But that's what happens inside the brain. It's new lesions, it's atrophy, it's development of new follicles inside the central nervous system that spew out antibodies constantly. So that's what's going on untreated. This is a fatal condition. Untreated, 7 years, average loss of life. So that's what we're dealing with. This isn't a casual condition that you take a medication and see how we do. This is a very serious condition, and thankfully it's not so well appreciated to be fatal because we've started with treatments and people have done far better since the advent of treatments. And this is a young lady. This is my mom as a young gal who developed MS, and here you can see with a cane, into a wheelchair at my graduation in college, to death due to MS. 62, which is the average age of death, untreated MS. So that's what we're dealing with. This is the condition. Now, fortunately, back in her day, the criteria were much more difficult to diagnose someone, meaning that it took a lot of damage to occur before we diagnosed someone with MS. And then about 2001, the McDonald criteria created to allow us to diagnose people at a younger age, or earlier in their disease state, I should say. And there was a modification in 2005 and another modification in 2010. And if you can see that well, we've gone from having to have many lesions in the brain to really just a couple of lesions in the brain in order to make a diagnosis. Caveat is we exclude other conditions that can mimic MS, and there are quite a number of conditions that can look exactly like MS from an MRI perspective, a spinal fluid perspective, a neurological physical exam perspective. So we have to rule those other conditions out. But when we do that in the appropriate age, with just a little bit of damage, we can make a diagnosis, start treatment, and protect you from the ravages of this disease. So this is how it used to be. If we wait several years before we employ treatment, we have a fair response to treatment, 30 to 35% reduction in relapse treatments. And if we don't treat at all, the vast majority will progress to the secondary progressive, slow, relentless decline in MS. So this is the situation very early on when we first were picking medications. And what we have to remember is there are a lot of statistics out there, and we can use just plain statistics, but each of you is an individual. And there's an art to this. We don't have an answer for every single situation, and we have to step back and not try to fit everybody in a particular box. So we need to also kind of apply our knowledge. And evidence-based medicine was something created back by Dr. Sackett a couple decades ago that wanted us to use the best available evidence and our clinical experience to make good decisions. Unfortunately, it's been distorted to just what did the trial say and what are the statistics. That's what evidence-based medicine has evolved into now. But just because we don't have evidence doesn't mean we can't use our available information and common sense to treat people. And the last point here would be in a study. Just because we haven't had a study to prove that breathing on the day of a full moon is necessary for life, I would still recommend that you breathe, okay? So there are a lot of different perspectives that we have and things we need to think about when we're evaluating a patient for treatment with our available agents. My goal, and I coined this term around 2000, was a home run of therapy. So I'm looking for 4 things out of a treatment intervention. One is for the medication to be well tolerated and safe, because after all, if we do well for 50 years on a treatment, but we feel lousy 1, 2, 3 days a week, that's not a win. If we sacrifice safety, that's not a win. No relapses, no neurological exam worsening, no MRI change. That's the goal that I empower my patients to look for in their treatment. And I think when you're empowered to do so, you're maybe more compliant in taking your medication. You believe, hey, we're striving for this. If we don't achieve it, we're looking to the next one. And I think that's the best way for best outcomes. And why do I choose those? Well, one is effective early relapses. When you have a number of relapses, your long-term outcomes are not as good. So in this particular graph, people who had 0 to 1 attacks in the first 2 years did much better with a disability score less than 6. Lower disability score is better. And then 2 to 4 is intermediate. Greater than 5 attacks in the first 2 years, worse outcomes. So relapses predict outcomes. And some of these people with 5 relapses had normal recovery of function. So it's not necessary, it's just the number of relapses itself can be predictive. And new lesions were the dominant factor on MRI scan in predicting worsening function. So we have here a study by Prosperini that looks at the number of new lesions. And what's circled here are 1 new lesion, 2 new lesions, 3 new lesions, and you see the odds ratio for a person with MS doing worse physically, neurological exam. And then you take those people, with a Greater than 1 relapse in the first year, it's higher than 1, so it's a risk factor. People with an EDSS score that's higher at 1 year, that's a risk for worse outcomes. But you see the number doesn't approach that of a new MRI lesion. And then you look at patients who have subclinical disease, meaning they're not having any attacks with these new lesions. And you can see the tremendous number of predictability. It's linear. More new lesions you have, the worse outcomes, and that's without any symptoms. So new lesions predict worse outcomes, independent of whether the lesion's associated with any new neurological finding. And this kind of shows this in a bar graph. New 2T lesion, T2 lesion at 1 year predicts worse outcomes, and each new lesion predicts worse outcomes. And this study as well, same thing. MRI activity at 6 months on interferon is the most specific finding for worse outcomes at 18 months, over the next 18 months. So that's why we get MRI scans when you don't feel any different, because they're very predictive of how you're going to do. And we should intervene when we have a window of opportunity before you're worse. We don't want to react to disability, we want to prevent disability. So if we have a means to say this predicts you're going to do worse, we need to do something differently, we should do that. Lesion growth predicting disability at 14 years, so same thing. And then we need to know that each relapse is not really friendly. So 40 to 50% of people who have a relapse will have a permanent neurological change of a half a point. 30% will have a 1 point increase in disability permanently. Never walk the planet the same. So it's not, let's try this medicine and we'll see what happens, and if we have a relapse then we might change, or 2 relapses. That may be too late. So we have to try to predict as best we can the right match of a treatment and where you're at. Now, clinical trials over the years have changed. So the very first trials before 2000, that dotted line's kind of the 2000 mark, patients were sicker. They had disease for longer. We were enrolling patients into trials who had a disease for 8 years, and their relapse rates were much higher. So the percentage decrease was not as good. And as I showed in a slide earlier, 30 to 35% of people will have a decrease in their relapses, or a 30 to 35% decrease in relapse rate, I should say, if you've had disease for 6 to 8 years. So if we wait longer, then we don't have as good an outcome, as you can see with these more modern trials where the relapse rate is much lower. So if we intervene earlier, we have better results. So this is kind of our perspective as clinicians when we're trying to decide on a medication. We need to think about the benefit of the medication, the annualized relapse rate, the disability progression, MRI changes. We need to, that's why you're taking the medication, to help reduce disability, to help keep new lesions and damage from occurring, keep relapses from occurring. So that's one thing we need to know when we're choosing an agent or choosing a switch. Start challenges. Before someone starts, we have to get labs or an EKG or eye exam, or be aware of potential drug-drug interactions. We have to realize that some people who have diabetes, maybe this medicine's not so good for them. Or they have hypertension, maybe not this medication, etc. Then we have to think about maintenance challenges. So a person's on a medication, we have to monitor laboratory values. We have to wonder about pregnancy. Oops versus desire. Accident happens. How does a person respond being on a certain medication versus, okay, I want to plan a pregnancy. What's involved in coming off a medication for that, etc. So I'm not going to go over each point. And then safety and tolerability, all the side effects, potential interactions, etc. There are a lot of things we need to think about in recommending or discussing our different treatment choices. It's not just, well, go look at 3 brochures, you decide which one you want, come back and we'll do that. That's what we used to do in the beginning, in the early 90s. We didn't have any knowledge, comparative studies. We didn't have as much knowledge as we have today. So here's the therapeutic landscape as of today. So betaferon is the European name, this betaseron. Avonex, Rebif, Copaxone, Tisabri, Mitoxantrone, Gilenya, Aubagio, Tecfidera, Lemtrada, and Plegridy. We also have Extavio, which is exactly the same as betaferon, so I didn't include that as a separate medication, but it's a different company that puts that medication out, but they're identical. And this is when it was first approved and the experience in clinical practice. So these are our choices, and we try to apply that to the perspective I just had and come up with the right choice. Oh, I forgot one thing. Insurance companies. So they kind of whittle this away and allow us to choose from menu number 1, and you have a certain amount of choices depending on your insurance, and then that opens up after that, et cetera. So this would be an ideal world. These are our choices for everybody at any point, but that's not the case. So I'm just going to give very brief blurbs or particular things about each agent. I don't mean to slight any one medication and favor one necessarily over another. I will spend a little more time with the most recent medication approved just because I think there's not a lot of knowledge out there about that medication. So interferon beta-1b, which is Betaseron or Extavia. With Betaseron, we have prolongation of life. So in a 21-year study, we saw really about a 7-year saving of life by going on this medication, and people staying on this medication at least 80% of the time over that length of time. So the first time now we've seen that using one of our medications actually gives you back several years of life. And NNT is number needed to treat. So the number needed to treat with Betaseron to prevent 1 death is 8 over 20 years. So we treat 8 people, we'll prevent 1 from dying in 20 years. With aspirin, to prevent a person from having a heart attack, it's 67. You need to treat 67. So NNT of 8 is a very good number. So our medications, and the other medications haven't been out long enough to do this analysis, so they may all do the same thing. But it's encouraging to know that our first one, the one that's been out the longest, has shown this benefit. And then we have Rebif, which is also an interferon beta-1a subcutaneous. It was the first medication to prove statistical significance over placebo in the 3 key elements clinically that I mentioned: relapse rate, disability progression, MRI accumulation. And there's a new injector which has made things much easier with this medication. Avonex, this is an intramuscular once-a-week medication that's responsible for us understanding clinically isolated syndrome or very early MS. This medication was tested, which gave us a great appreciation for treating earlier. So this medication was responsible for that. And there's a new pen with this medication that makes injection so much easier. Copaxone or glatiramer acetate now has a 3 times a week option, which saves over 200 shots a year, which has been a very welcomed addition to our armamentarium. It's Category B for pregnancy, which gives women comfort if they happen to become pregnant while on this medication. And it has a long history of safety. It was the 2nd medication that came out after Betaseron. And here's a study showing that the 40 milligram dose 3 times a week as opposed versus placebo had statistically significant benefits, which allowed us to use this medication in lieu of the daily injection if we wanted to. Now, pegylated interferon beta. This is the new medication called Plegridy. So this is basically Avonex, which is attached, many Avonex molecules, to a core particle. And it showed statistical significance in a recent study that's allowed it to be approved. And this is a subcutaneous injection every 2 weeks as opposed to a once-a-week intramuscular injection, another way to give the Avonex molecule or the interferon beta 1a molecule. Now, I disagree with Stu. You do have to know everything that Dr. Riser and I talk about today, and you cannot look at the YouTube videos because you already know it, so just pay attention. And this just goes into how this medication is given, 125 micrograms every 2 weeks. There's a graph that's a little hard to read, a little small, but the red bar is a placebo-treated group, and you can see that they have relapses sooner than patients who were treated with this medication every 2 weeks or every 4 weeks. And some of the side effects we're very well aware of. So there were no novel side effects with this medication over Avonex, so it has the same side effects that we are accustomed to seeing with Avonex. And then fingolimod or Gilenya is a medication that's had 3 studies that have led to its approval. So this is just kind of the face sheet on this medication. This is how it works. It internalizes this S1P receptor on T cells, and that doesn't allow the T cell to escape from the lymph node. So it's trapped in the lymph node, those activated T cells that can go to the brain and spinal cord and cause lesions. So that's how this medication works. Now, there have been some PML cases in patients who have come off natalizumab and gone to fingolimod. And I just put this out here because we all have to have knowledge, and there are checks and balances that help everybody. And as everybody probably knows, there's a risk of this brain infection, PML, on people who are on Tysabri if they're JC virus positive. And when we come off the medication and go to another medication, we have to be sure that we've checked an MRI scan somewhere in there to exclude the possibility of PML. PML doesn't always cause symptoms when it's detected. So if we switched and we treated with another medication that suppresses the immune system or alters the immune system, and they have PML, we may be doing harm. So we need to know when we're switching a person that they do not have evidence of PML before we start the other medication. Really important, because these cases have occurred probably due to Tysabri, and then they went on Gilenya, and they already had MRIs, if you look back, that were consistent with PML, and it was missed. So, you can, if you're switching, you're in that boat, you say, I need an MRI scan before I start this medication so that I can exclude the possibility of PML. There was the first case of PML this February in someone who was on Gilenya who had not been treated with Tysabri before. So that's one case in 135,000 treated people. And it's a very weird case in that the patient had evidence of PML in 2 different areas of the brain, had no symptoms. It was picked up on a routine MRI or a monitoring MRI scan, had very low numbers of the JC virus in the spinal fluid. And our last patient that had PML, for example, had 69,000 copies in the spinal fluid, and this person had less than 100, and 2 lobes involved. So it's a very strange case, but 1 out of 135,000 is the number. Then we have Tecfidera, or dimethyl fumarate. So this is a medication, an oral medication given twice daily. It was approved because of 2 studies, the DEFINE study and the CONFIRM study, which showed statistical benefit of this medication. Mechanism of action is a couple. One, it helps with oxidative stress in the brain, so this complicated pathway, NRF2 pathway, it helps to intercede here and prevent inflammation and tissue damage. The product profile in one of the studies is listed here. So it's 240 milligrams twice a day. The 120 milligram twice daily dose was also approved, but usually as a titration dose in the first week. Here are the side effects of the medication. Gastrointestinal side effects and flushing are the most common. If I went back to Gilenya, it's a low heart rate, about 4% of patients, and macular edema or swelling in the back of the eye, which is less than 0.5% of people will have that problem. So highlighting the more common side effects or unique side effects of these medications. Now in October this last year, there was a first case of PML associated with this medication in a patient who never had Tysabri before. Now this person had had low white count or low lymphocyte count for 3 years. And we're not sure, with this being only one case, whether that's the prerequisite for someone on this medication to develop PML or not. We don't know, with only one case having occurred so far. But in other words, both of the oral medications Gilenya and Tecfidera have had one case of PML in over 100,000 treated patients to this point. So the risk is extremely rare to this point, and there may be unique abnormalities in these individuals we don't know. We'll know over time with incidence, I think. Teriflunomide or Aubagio is another oral medication we have available that's a once-daily pill. There were several trials that led to this medication's approval. And whereas the relapse rate reduction is not so robust with this medication, it is significant. It's the only medication that has 2 phase 3 studies that show statistical benefit on disability progression. No other medication we have available has statistical benefit in 2 phase 3 studies. Its mechanism of action, it works in the mitochondria, and it helps reduce activated lymphocytes from being produced. So activated lymphocytes, like T cells, need more metabolism, higher metabolism through the mitochondria to kind of increase their numbers when they're activated to go cause lesions. And this medication stops that pathway. The salvage pathway, or the low-rate energy metabolism pathway, is unaffected by this medication. So it does not damage resting cells, for example, or low metabolic cells pathways. Tisabri I mentioned. Prior to Lemtrada, the last medication I'll talk about, it was the most efficacious treatment we've had. So sometimes we need to think in terms of MS being a torrent and being fatal, and the risk of undertreating the medication and having a poor quality of life is something we have to take in consideration with this medication and its low risk of developing PML. So it's a balancing act, it's an individual discussion, it's a risk threshold discussion that we have with our patients before deciding on this medication. And we'll be clear on this risk. At 6 years on Tisabri, if you're JC virus positive, the risk is less than 1% of developing this brain infection, or in other words, 99.3% risk of not developing PML at 6 years if you're JC positive and take this medication every month for 6 years. So yes, it is a risk. The risk has some significant consequences, but it is a very rare risk. And what is the risk of disease progression and permanent damage? And those are the kind of discussions that we need to have in clinic. This medication also helps us with compliance, because if you don't show up for your monthly infusion, we know you're not taking your treatment. And that can be a problem with some of the other medications, and they don't work if you don't use them. And this is the mechanism of action. You can see in the yellow, you can see Tisabri here, which interferes with the binding. Up here as well, the lymphocyte with the blood vessel and the sticky portion of the blood vessel, it intercedes so the blue cannot bind the green, and therefore the cell cannot get into the brain and cause brain or spinal cord lesions, and that's over here as well. The yellow is interceding between the blue and the green and not allowing the lymphocyte to get into the brain. Mitoxantrone is still available. It's rarely used because of the risk of leukemia. 1 in 150 patients, we estimate, and also has some congestive heart failure risk, which we know about, we can monitor for, but it's rarely used. It's very, very effective, but rarely used because of its safety issues. And that brings us to alemtuzumab, which is the last approved medication that we've had. It was November 14th of this year. And if you attended the talk last year, I talked a good bit about this medication and the fact that the FDA had not approved the medication. And I think they made some decisions on some misinformation. And we wrote letters to all our patients to write to the congressman if they felt that was appropriate, to lobby for having this medication looked at again and approved. And Stu was really instrumental on an online petition, and through his website, had thousands of patients sign that petition. And it was your voice that turned the FDA around. They said as such, that it was driven by your voice and your passion to have this medication available. It doesn't mean that it should be for everybody, but to have another choice, because it is the right choice for some people. So this medication targets a receptor on lymphocytes, the CD52 receptor. And this is on B cells and some T cells, not all T cells. It binds this molecule, this receptor, and it kills the cells. So it knocks out the B cells and some of the T cells. And so this is probably why we have a lot less inflammation and attacks, because we've knocked out the major players causing lesions and inflammation. Now, the distinctive pattern on how it knocks them out, and then your bone marrow regenerates lymphocytes, knocks it out a year later, and then you regenerate again, may eradicate the right situation or the lymphocytes that cause MS. So that may be responsible for why we see long-term positive benefits, and yet you only take this medication 5 days IV the first year, 1 year later, 3 days IV, and then you may never need to be treated again. And what we saw here then to give evidence for approval was the annualized relapse rate versus Rebif, so versus the first medication that had proof of benefit in all three important arenas: relapses, disability, and MRI scan. So that's why that medication was chosen, because it was the most powerful perceived at the time statistically. And we see sustained accumulation of disability at 6 months significantly better than a very active agent, an agent that works rather well. And then how about improvement? So we see now not only prevention of worsening, but we see neurological improvement, getting better. Not just keeping us from getting worse or slowing down worsening, but here we have 29% sustained reduction in disability or reversal of some disability out 2 years versus 13% for Rebif. And the average patient you see has a lower neurological score on an objective exam 2 years after being on the medication. Neurologically better 2 years later. This was the starting point, that's the end point. Now you need to memorize this slide, and we do have a quiz during that break that Stu talked about, okay? So I'll give you a minute to look at it. No, this is a poster I'm going to be presenting in Washington next month, so no one else has seen this before today. And I better study it. So I'll get to the skinny. These are the results. This was an extension study of the Lemtrada study that we had. So this carries it out 4 years since the last dose, or 5 years from the first dose administered. 93% of people went into the extension study, which is remarkable. Through the 4 years, the 2 years of the core study and the 2 years of the extension, approximately 70% of people required no further treatment. 24% had 1 additional course of the Lemtrada, 7% had 2 additional courses, and 5% switched to another agent. So at 4 years, 95% of people still on this treatment. That's pretty remarkable. Here we see over 4 years now, still not worsening of the neurological outcome, despite not having anything for now 3 years. So the outcome versus the start. And then patients who have had sustained reduction in disability, improvement in their outcomes. 3-month sustained benefit, 6-month sustained benefit, and 12-month sustained benefit, meaning no worsening in exams separated by 12 months or 6 months or 3 months, really significantly high, despite not having a treatment since here, month 12. So better, getting better still at 4 years, last treatment at 1 year. And this is, I guess, didn't squeeze in as it did on my laptop. But this is sort of a summation of that. So 44% of patients improved, 28% stable on their score at 4 years compared to baseline. 11% of patients had a whole 1-point improvement, 5% 1.5 point improvement, and 7% had a 2-point disability improvement. This is on a 10-point scale. So that's significant at 4 years. And then it breaks it down. People getting better if they were stable or improved in the first 2 years, they kept getting better. Patients who were stable in the first 2 years, 19% then improved from year 2 to 4. And if patients had worsened from year 0 to year 2, a 35% improved then in the next 2 years. So this is a medication that keeps on working and improving things years after it's been taken. It demonstrated a durable effect in reduction over the 4 years, despite most patients only receiving the 2 courses at month 0 and month 12. So very, very positive results with this medication on the long haul. Side effects, which I didn't mention, but fair and balanced, thyroid disease can develop in 1/3 of patients, either overactive or underactive, which requires treatment. There were 2% of people who had an autoimmune platelet condition develop, which to this point, after the first patient was discovered, have all been cured. And then there were 4 total renal cases, kidney cases. 1 who needed transient dialysis and immune suppressive therapy is now back to normal kidney function, not taking anything and not on dialysis. Last medication I want to talk about is Empira, which improves signaling through scarred tissue. This is not a disease-modifying medication, but it's a medication that can help your function, help you walk better, help you walk faster, help your endurance in a lot of functions. And this is how it works by keeping the shorting out pathway from shorting out so much. More signal to go where it needs to go. Diet. There's so many diets proposed out there in MS. Vitamin D is certainly very important. We see that people with lower vitamin D have higher rates of relapses, higher incidence of developing MS, and kids who have vitamin D deficiency, they may have worse outcomes if they start out with a low vitamin D. They're non-dairy, vegetarian, Wall's diet, a doctor who in Iowa who went on this particular diet and got better back to normal proposes this diet, which is a very rigid diet, paleo diet, gluten-free. You can find people espousing all of these things. Unfortunately, there's no proof of any of them. There's no study, and it's going to be nearly impossible to have a study to prove these things because people are on different medications and their courses are different. It's very, very difficult. I think it's important to be on a diet that is right for a given individual, and those are things that we should discuss. I think in general, white sugars, carbohydrates, we should have less of those substances because it takes more energy to metabolize those. Wellness, self-esteem is very important. Who you're around and a positive outlook is really, really important. Who do you have on your team? You need to look at that. Energy, this is for wellness. Sleep better. Need to remove negativity. Medications may cause decreased energy. We need to know that. And then different things we can do, stay cool. Take a nap or rest when you need to. There are medications for energy. With mobility, the answer to immobility is mobility. So working towards more mobility. And we'll hear more about that in the afternoon session. So I won't belabor that point. Cognitive challenges. I think we all have problems with this one. And then tips are to stay organized, to write things down, to put the keys on the same hook every time you come in the door, to be very regimented. That's not having to challenge your brain. I'm working hard to get this done here in a second. Emotions, very, very common to have depression due to lesions in MS. So it's not just that you're feeling sorry for yourself, it's actually lesions don't allow chemicals to go to the mood center as they ought to, so it's the condition itself. And I'm almost done. Taking your MS therapy, as we saw, is very important. Final tips, be an active partner in your care, have a positive outlook. We all have a set of cards that we're dealt every morning we get up with, and you deal with them. The past doesn't matter. What you had yesterday, your hand doesn't really matter. It's what you do with what you have today. Have a sense of purpose. Don't stress about things. As far as I know, God wrote the last chapter already, Revelations, and our worry's not going to probably let him come back down and rewrite that chapter. So we don't have to worry about things. Doesn't mean everything's rosy, but we don't have to worry about it. And I think Last thing, nicotine. Smoking is associated with a higher incidence of MS. It's associated with higher relapse rate and worse outcomes. It's a hard habit to quit. We can help. Tornado's over. Here we are. Thank you very much for your attention. I'll answer questions after break.
So sorry to make it sound like we're like in a competition here or having a race, but we do have a lot of people speaking here today because we wanted to give you a very comprehensive look about many things to do with multiple sclerosis. So next up, we're going to have Dr. Emily Riser. She'll speak for about 35 minutes, and then we're going to have lunch served, and then we're going to get to the Q&A. And I'm sure you're all going to have a lot of questions. So there's pads on the tables. You were given pens. Remember, our name is on those pens. And, please write down your questions, and let's get started.
Let's do this thing. Yeah.
That's right. Dr. Riser, thank you.
Thank you, sir. Good morning. How is everybody? Okay, what I want you to do is I want you to stand up first, if you can, and stretch, okay? Everybody, we'll do a little bit of this. We're going to do a little bit of that. We're going to come up. We're going to go to the right, left. Okay, and then I want you to take a little sip of water, but not too much, because we know what happens, right? But everybody just stretch, take a little sip of water, and then we're going to just drill down on this and make it fun. Okay, y'all ready? All right, let's do this thing. That's my motto now, let's do this thing. So, Stu, thank you for having us. Dr. LaGanke, thank you for that amazing presentation. It's extraordinary that you're able to synthesize, 20 years worth of data in a talk like that. I'm always so impressed to hear you speak. So I have the daunting task of addressing something called emerging therapies in MS, and then to hit briefly on relapse management. Now, I am an old girl, okay? I trained in the dark ages at UAB back in the 80s with Diane Sawson. There she is, shout out. And Dr. LaGanke, who stayed on and did his work in immunology. I drifted off for years. I came back to the faculty at UAB, where I then became certified in neurorehabilitation and neuroimaging. And it was at that moment that a light bulb went off that I realized that my calling in life was to take care of people that had this disease called MS. And that is what I have done. And that is my commitment to you. That's what gets me out of bed every morning. I absolutely love it. We did not have a therapy to treat MS until 1993. So for those of you that developed this disease before then, you know exactly what you had to deal with, and it was tough. But we live in an extraordinary time. We live in a time where there's amazing discovery, and we're going to try to go through a little bit of this. Dr. LaGanke talked about the current landscape. We have 11 therapies. It's quite extraordinary. We don't give you a box of 3 things and say, you go home and decide what you want to be on. He and I share the same philosophy, which is this disease is inflammatory, degenerative, and progressive. It needs to be treated early. It needs to be treated aggressively. And so he and I are the first ones to tell you, we got to do this thing, and we got to do it right now. We're fine with you adding on complementary and alternatives, but at the end of the day, we need to apply wisdom, as he said, to this. We need to get after this early. So this is a slide, and this will be on the test too with his slide that he told you. But at the crux of this, you guys, this is the pathology of MS. MS is a disease that causes both inflammation and degeneration. And when you look at this cartoon, basically what you see is over on the left-hand side, you see the blood vessel and all of the immune response, the things that are going on to help us fight germs and fight cancer are happening in the bloodstream. And these things are going on there for a purpose. But for reasons that are poorly understood, there's a cascade whereby proteins that are being expressed inside the brain on the insulation of the myelin begin to look like something terribly foreign, or what we call antigenic, terribly foreign or antigenic to the immune system. So these cells, which we will call lymphocytes, these cells take on their own identity. They cross this thing, as you see in the middle, called the blood-brain barrier, and then these cells go into the nervous system where they set up shop and create a whole cascade of inflammation and degeneration. So when we think about emerging therapies and we look at this cartoon, we have an extraordinary opportunity to get after this. Okay, we really have an extraordinary opportunity to get after this. So let's remember that all of this starts with something called the lymphocyte. A lymphocyte is a cell, it's an immune cell, but there's subpopulations of lymphocytes that we need to think about as we think about that cartoon. We need to think about T cells and B cells. And I'm here to tell you that there is a big uptick right now in thinking about B cells. Many of our therapies to date currently have an impact on T cells. But this B cell is getting a lot of attention. And the reason being is the B cell makes antibodies. And these antibodies can be good because we want to, get rid of, mononucleosis and the flu and everything else. But these antibodies can be really bad. And what we're finding is that these B cells have something on their surface called CD20. Dr. LaGanke talked about CD52 when he was talking about alemtuzumab. Well, these B cells have something on their surface called CD20. So we have an extraordinary opportunity by thinking about interventions to get after the CD20 receptor expressed on the B cells. And when you look here at this cartoon, this is a cartoon of a neuron and the axon and the insulation, which is in pink or kind of a reddish color. Not only are T cells in that space ginning up activity, but that B cell is making those blue things, and those are antibodies. So these antibodies can be good, but these antibodies can be bad. And not only are these B cells making antibodies, but these B cells are setting up little bitty pockets or nests, what we call germinal centers in the central nervous system. And we now know that these little patches of B cells are hanging out really close to the meninges, and that this activity is ginning up all the time. So when you come to me and you say, I have fatigue and I have pain and I'm just not thinking right, I believe you, because we know that the pathology of MS is one of inflammation and then secondary degeneration. And as a consequence of this activity, these lymphocytes being activated, these T cells, these B cells making antibody, they continue to cause issues for you by virtue of laying down these scars in the central nervous system. This is an MRI scan of someone with MS, and this is typically what we see. Multiple periventricular hyperintense lesions. And these lesions are a direct manifestation of the abnormal activity of the lymphocytes. The T cells making bad things, and the B cells creating antibodies. So how do we get after this? What are the game changers going to be as we move closer to finding a cure for this disease? Well, my hunch is it's not going to be one thing. By and large, it's going to be combinations of things as we think about the pathology of that first cartoon that I put up. So first thing is we got to change the way the cells behave. We've done that to some degree with beta interferon and glutamer and these other drugs. But we've got to keep sometimes lymphocytes in the lymph nodes. That's where they hang out. We've been able to do that with Gilenya, and there's some other emerging therapies that are S1P drugs that are going to be like Gilenya. But really what we have to do, we have to specifically alter the way these cells behave. And we can do that by creating something called a monoclonal antibody. A monoclonal antibody. So are there any monoclonal antibodies commercially FDA available to treat MS? Yes. Natalizumab, which is Tysabri, and alemtuzumab, which is Lemtrada. So if anything ends in M-A-B, MAB, it is a monoclonal antibody. So natalizumab is a monoclonal antibody. Alemtuzumab is a monoclonal antibody. So what are the new strategies as we go forward? Well, Thank goodness the FDA finally approved Lemtrada. Whoop, whoop, okay? It's a game changer. It's a monoclonal antibody. But we're getting ready to move into remyelination strategies and stem cell transplantation. So this is happening. I was there in 1985. And when I stand here and I see you guys, I can't help but just get really excited about this. There is so much going on in this space. It's incredible. So what is a monoclonal antibody? Well, a monoclonal antibody is an antibody. It's made by an immune cell called a plasma cell. It's pre-treated with mouse protein. So if I lean heavily on one of my really smart scientists down at UAB and I say, hey, we need a monoclonal antibody to do this. They think about it. They come up, they pre-treat these little mice with antigen, and then what they do is they genetically program this so that it will do something specifically in the immune system. And this is how they do it. Poor little mouse. But anyway, there he is hanging out down in his cage at UAB. And one of my dear friends, Tara Da Silva, does this kind of work. But basically, what they do is they take an antigen. Remember I told you an antigen is a foreign protein, is something that our immune system does not like. So they'll take an antigen, they'll inject it into this poor little guy, and then this little guy suddenly will make cells called plasma cells that express this green antibody on the surface. And we can combine that with tumor cells and create this thing called a hybrinoma, and then from there, we can just gin up as much monoclonal antibody as we want. So this is pretty cool, and this is actually how they do it, okay? So we thank our little guy. He's really making a huge difference. So this is basically, under the microscope, what a monoclonal antibody would look like. And so we can inject it either intravenously or subcutaneously and program it to do something that we want it to do in the immune system. This is a lymphocyte in green. It looks like some kind of toy that my kids used to play with when they were really little that they throw at each other. But this is a lymphocyte in green, and it is expressing a whole host of different things on its surface. T cells and B cells, the lymphocytes. These things are characterized in the CD classification. CD52, CD25, CD20. Remember we talked about CD20 being on B cells. So these antibodies are programmed to do something highly specific to the immune system. And that's why we're getting these extraordinary outcome measures with the MAB drugs, with Tysabri, with Lemtrada. These are game changers. These are monoclonal antibodies. So what are some emerging monoclonal antibodies that we're going to see in this space that you're going to hear about? Well, I've listed just 4, but there's a whole host of them. There's not going to be a test on this, but I want you at least to know the nomenclature, just some of the things that are there that are being tested that are on the horizon. The first is rituximab at the very top. If you'll notice, every one of these ends in MAB. These are monoclonal antibodies. Rituximab is an anti-CD20 monoclonal antibody. It's been used off-label for patients with multiple sclerosis for quite some time. There are several researchers around the country that have really been using this as their go-to drug for breakthrough disease, and they've put together small, trials looking at this up through phase 2. I don't think that this is going to be anything that'll go into phase 3 because it's not totally humanized. It's a little bit more of the mouse than a person, but suffice it to say, rituximab is very, very effective in lysing the really bad B cells that are making the antibodies that are ginning up all that activity in the central nervous system. All right, daclizumab, olacrizumab. So rituximab, like I said, it's given intravenously. One concern is PML has been reported in a lupus patient receiving rituximab. So we need to be aware of all these things, risk and benefits. Daclizumab is an anti-CD25. It will have an impact on T cells and B cells. Biogen IDEC, I think, is putting in a request to the FDA to get approval for this. They've already completed their trial. It was the DECIDE trial. It was a phase 3 looking at 1,800 patients randomized to receive daclizumab, 150 subcutaneous versus Avonex. which is just traditional gold standard treatment with positive impacts on the typical metrics that we always look at in clinical trial, which is relapse rate reduction, the MRI, and disability. So to be continued. I think we're looking at 2016 is my hunch on that. Ocrelizumab, we'll have a little fun time, spelling and pronouncing all of these. But this is another mAb. It's an anti-CD20. It's highly humanized. It's given by infusion. There's two phase 3 trials going on, one phase 3 for primary progressive. I'm excited about that because I think that is an area where we really are lacking efficacy in terms of altering the natural history of that disease. Another mAb, which is an anti-CD20. This is already in the leukemia space. So I think what we're seeing is our scientists are going back and grabbing some of these mAbs that are already there, for example, that are being used for RA, for leukemia, for cancer. And they're saying, hey, we think that these things are going to positively impact multiple sclerosis. We need to do this. So these trials are very important. So they're enrolling. But what about remyelination? Anyone that's had an MS relapse knows that it never really goes back the way it was, okay? Whether it's an optic neuritis, whether it's a transverse myelitis, whether it's some ataxic spell, whether it's a cognitive issue, the steroids and everything that we do impact recovery to some degree, but at the same time, we have not really gotten our arms around the whole notion of neural repair and neuro recovery and neuroplasticity. You can use all these words interchangeably, but this is at the crux of the new wave of discovery in this space. And I'm excited to tell you about a couple of things. So neural repair is going to consist of things. One is at the very top called anti-1 lingo and then stem cell strategies. Now, Dr. LaGanke is part of the anti-lingo trials, and maybe he can answer some questions along those lines if you have those after I finish my discussion. But we'll talk a little bit more about that. We'll talk about stem cells, mesenchymal stem cells, hematopoietic stem cells. We get a lot of questions about stem cells, so we'll try to address that. Now, anti-lingo 1. This is something that Biogenidec has, and basically lingo 1 is a protein that's expressed in the central nervous system. And its primary role is to prevent remyelination and repair. So we do not like lingo. We are anti-lingo, okay? We don't like lingo. Lingo is expressed in the central nervous system. Its sole purpose is to prevent remyelination. So if we can give, guess what? A monoclonal antibody, we can lean on our scientists and tell them to put that antigen in that mouse, to make that plasma cell and mix it up with that tumor cell and give us that hybridoma that makes anti-lingo 1. Well, they have done that for us. They have made an anti-1 lingo and monoclonal antibody that's being tested in clinical trial. Now, this is given intravenously. They have two trials. One is the Renew and one is the Synergy. The Renew trial is fascinating, and we've had some preliminary results on it. The Renew trial is fascinating because what they're looking at in the Renew trial are patients with optic neuritis. Optic neuritis is the absolute best model to study anything in because, number one, as clinicians, we can see it, we can take a picture of it, we can measure it. It's highly objective. It's very quantifiable. So the model of optic neuritis is the best model to study any MS therapy in. So they're studying anti-lingo 1 in the Renew trial in optic neuritis, and they are finding that it has a profound effect on improving something called the visual evoked response. So patients are getting better, which suggests that there is indeed remyelination of the optic pathways. This is exciting. You start coupling this on top of other therapeutic monoclonals, now we're talking about success, okay? The Synergy trial is in progress right now. They're not enrolling. This is the trial that Dr. LaGanke is a part of, so I'll be anxious to hear his thoughts on this. Stem cell strategies. That's why you came today. I mean, we could talk for hours about stem cell strategies, but we have to remember that stem cells come from many places, and we're not talking about embryonic stem cells. We're talking about autologous stem cells. We're talking about stem cells that belong to us. These stem cells can either be mesenchymal or they can be hematopoietic. Mesenchymal or hematopoietic. So if something is mesenchymal, you can get it from several sources. A lot of people are banking umbilical cord blood. There are banks that do that. That's probably the most naive and easy to get, umbilical cord blood. Adipose tissue, hey, we know where that is. It's right on the sides, right over here. Muscle, skin. Turns out little bitty children have a tooth that has a lot of stem cells in it. So we can bank stem cells at early ages, mesenchymal stem cells. Now, a mesenchymal stem cell trial will be something where the scientists would take those stem cells from that tissue, and then they kind of multiply it and give it back to you in hopes that it would provide neural repair. Okay, there's not a lot of phase 3 trials going on with mesenchymal. There's a lot of phase 1s. Jeff Cohen at the Cleveland Clinic's doing it. They're doing one at Tisch. There's a lot of places you can go to clinicaltrials.gov to learn about mesenchymal stem cell studies. And there's not anything available here in Birmingham that I'm aware of. But I think the stem cell transplants that are getting the most attention are the hematopoietic stem cell transplants. And you will see this listed here on the slide, HSCT. So when someone says they're talking about HSCT, they're talking about hematopoietic stem cell transplants. And basically what we would do is go and get stem cells, hematopoietic, from the bone marrow or the blood, autologous. And then we would take those stem cells out and then put you through a treatment where you would receive chemotherapy plus or minus radiation therapy to eradicate the bad immune system that you have. Granted, there could be some dicey side effects associated with that, but these things are done inside of a clinical trial, done by experts, done by people who know how to manage and to mitigate risk. And this is being done effectively at places around the country, okay? Hematopoietic stem cell transplants. I think this will be one of the first things that we see come to fruition. This is a cartoon of the bone marrow. It looks like a little birdhouse up there, or like a little, I don't know, a little igloo or something. But that's our bone marrow, and as you can see, the cells that come out of the bone marrow, they're very naive, and they can be trained and taught to do all kinds of things. So in hematopoietic stem cell transplants, we can go and get those cells right there, okay? So National MS Society is funding about 10 trials right now. There's gazillions of dollars being, put into this. I think this is very worthy. I think it's got an incredible future for those of us that are in this space. I think the most famous one that everyone knows about is the work at University of Chicago, Northwestern with Dr. Burt. He has done several of these stem cell transplants. I have a patient that's actually received one. She's doing very well. It was kind of an out-of-pocket expense by going through his center. It cost about $125,000 roughly to do something like this right now. I doubt Blue Cross Blue Shield of Alabama is going to pay for it. Or United Healthcare. Yeah. So, anywho, but you can reach him. He's doing a trial right now where they're looking at 2 arms where they're doing hematopoietic stem cell transplants versus traditional therapy, and they're enrolling. The NIH has sponsored a really good trial called HALT, and they are no longer enrolling. It's a 5-year trial. They just reported their 3-year data, and there's like 78% of participants are showing no new disease activity on no disease modifying therapy. So this is extraordinary. So to be continued. Stem cell research, I just want to say one thing. We don't want anybody in this room to go off anywhere and get, quote, stem cells. All right? Dr. LaGanke agrees with me. We have concerns about outside stem cells. These places all around the world We have concerns because there's no published medical evidence or safety data. We have concerns about the sanitary guidelines. We have concerns about where they get these stem cells. We have concerns about the procedures that they use to harvest these stem cells. We have concerns about graft versus host disease. That's where someone takes an external source of stem cells and they could come down with a bad neurological inflammatory lesion, or these cells could even proliferate and become tumor cells. And we are very concerned about follow-up care. So we do not advocate at this time that anyone in this room seek out stem cells unless they're being done in an academic center, in a clinical trial, and/or in a center for compassionate use. Okay? So quickly, what's going on in the world of relapses? This is how we treat relapses. A relapse is a new neurological event that lasts for more than 24 hours. It can be anything, as y'all know. Typically, we treat with IV Solu-Medrol, high-dose steroids, or Acthar. Dr. LaGanke and I will tell you, in the dark ages, we used to use ACTH, Acthar, that treatment for 14 days. And we're kind of pushing towards, looking at this more carefully because of the following. ACTH is natural. Solu-Medrol and prednisone and decadron are synthetic. ACTH is natural. It comes from our pituitary glands. It is released, and then it goes down and it stimulates that little pink thing called the adrenal gland. The adrenal gland makes steroids, cortisol. Cortisol is anti-inflammatory, and that is what gets after the relapse. So if we think about it, if we can use something that's natural, it may very well be more effective. And the reason we think it's more effective, because we believe that there's this new emerging pathway for ACTH in something called the melanocortin receptor theory. But we know that there are melanocortin receptors all in our body. But the one on the adrenal gland is melanocortin 2. So Solu-Medrol impacts melanocortin 2 only, but we also know that there are 5 of these. And these 5 melanocortin receptors, if you look, 2 is on the adrenal gland, but these other ones are on the immune cells. They're on the lymphocytes. Other ones are in the brain, in the hypothalamus, in the spinal cord. So if we're going to think about effectively treating a relapse, we may begin to lean more towards the natural and less of the synthetic. And our center is currently doing a trial. We're going to publish some of our data at the consortium next month, but we're looking at a trial where we're using Acthar for acute relapses, banking blood, looking at the genomics of what's going on in the blood at the Hudson Alpha Lab in Huntsville, and then using high-field imaging at Auburn University with a 7T MRI. So to be continued, but I think that there's a story here. So the therapeutic benefit of Acthar, the nice thing is you have fewer side effects because the cortisol levels are lower, and you have this immune modulating impact on the system, which we do not get with IV Solu-Medrol or prednisone. So my final thoughts are, this is an extraordinary time, hence the rainbow. I actually took this picture on my iPhone. Steve Jobs, you've come a long way, man. This is a picture that was taken on the ferry about 2 weeks ago as my family traveled out from St. Thomas to Tortola, but we were passing by St. John, and I saw this incredible rainbow over St. John, and it just dawned on me that there's hope, that this is an extraordinary time, and I think that you're going to see all of this come to fruition. So again, I want to thank Stu and everyone here for giving me the opportunity to share these thoughts with you. Thank you.
Has anybody determined whether MS is inherited? Is my offspring?
Sure.
My wife
Yes.
had it. I have it.
Okay, question is MS genetic, basically? And it is. So we know that there's a genetic component to this condition. There was a Canadian identical twin study done, 270 some odd twin pairs, and saw about a 300 plus times increased incidence in female-female identical twins, 45 time increased risk in male-male identical twins. We know that there's a strong component. There are many, many genes involved. We haven't found them all by a long shot. We've identified quite a number of genes that are involved. The thing is, there's probably more than one gene that a person has to have. It's kind of like they have a set of genes that makes them susceptible to something in the environment. So it's both. You have a genetic background and then an exposure to something that creates this condition. If you don't get the exposure, even though you had the genetic background, may not see it. And the incidence is really 2.5% or 1 in 40 offspring or down the road. So if you have 2 per family, so that's 20 families, 10 generations each side, you may not see it at all in your family, back or forward, but it's there. And then I have some family members, six family members with it. So some genes are very highly conserved and passed on, and others you need a combination and then an exposure. So we're still vexed by not knowing the cause exactly, but we definitely believe there's a genetic component to it, and then an environmental exposure is necessary.
And one additional thing is that, when you look at identical twins, the concordance rate is really quite low. I mean, it's 35%. So you have the same genetic fiber in 2 people. I have sisters that are twins, and, one of them has it and the other one doesn't. So like Dr. LaGanke said, I mean, there's something more to this than just this polygenetic component.
Yeah, so to follow, if it's 1 in 1,000 who gets this disease in the general population, here you had 35%, which is 350 times the general incidence, but it's only 35% in identical twins. So yes, there's a genetic component, but it doesn't answer everything.
Dr. Riser, for the benefit of everyone, I will repeat the question that I asked you out in the hallway about several years ago. I was at a seminar where you spoke, and there was a lady who had gone to Germany for stem cell treatment. And I just asked you about how she was doing. Will you repeat your answer?
So the question has to do with going to stem cell shops outside of the United States. And I'm sure Dr. LaGanke would like to weigh in on this. Our personal opinion is that the best stem cell research is being conducted, in clinical trials in academic centers, following very stringent protocols, gathering data sets and information that we need to understand, how this is going to impact many chronic diseases moving forward. But a lot of individuals, and I get this. I mean, I'm in this space with you, and I get this. Just like, Chris's mother had MS. We get this. We understand that sometimes individuals feel a sense of desperation that they may need to do something. They've run the table, they've tried all the injectables, they've done the MABs, they've done everything, and they feel a sense of urgency because they're getting to where they can't walk, they can't transfer, they can't get out of the bed. The quality of life stinks, and so they wander off somewhere. And I get that, but the answer is that the way that was delivered in that particular patient may not be the most efficacious way to deliver stem cells, as we discussed in our conversations. So I don't think that type of stem cell transplant is translational in terms of giving us the data that we're seeing in the HALT trial. I don't believe that in my heart of hearts. So I would caution everyone about, stem cell shops outside of the United States, outside of academic centers.
Yeah, and I'd agree. I mean, Emily laid it out really nicely, the problems of getting stem cells in an uncontrolled environment. We don't know what you're getting. You don't know what you're getting necessarily, and that's a problem. We still have logistics. I think stem cells is a great concept, great idea, and we hope is extremely impactful in remyelination. But we don't know how to get the right amount to the brain, what the best route is. All of these things need to be worked out in a clinical study. And to just randomly receive stem cells, which, if they are stem cells, we would hope, we don't know what's going to happen, and maybe a huge cost for nothing. You give $20,000 for stem cell treatment in Latin America and nothing happens. And did you really get stem cells? Were they harvested correctly? Do you have complications potentially? So as much as we would love to be able to provide this and work on remyelination, we're just not quite there to say that this is an appropriate amount and in the right way given. Spinal tap, direct brain injection through blood, we don't know those things yet.
Also, maybe for you to address that, when people do go out of the country, who's going to care for them when they come back?
Right. What kind of follow-up? What kind of protocol was used? What sort of things? Were you given a chemotherapy to suppress the bone marrow first? And that may have lots of complications. A lot of chemotherapies cause secondary cancers down the road. So we need to know what was given and how much and be alert to all those facts. So there's a lot that's to this.
In relation to this topic, what about those centers in this country that take stem cells from adipose tissue and that kind of thing? How do you feel about that?
I think that we just have to be very cautious about some of these centers. Our best recommendation, I mean, obviously we are applying wisdom to this, right, Diane? But as it pertains to stem cell research, it really needs to be conducted in academic centers. Because there's a lot of the methodology, the delivery, the outcome data, the safety issues. All of this really needs to be managed in an academic center, where these clients are, being monitored, where we're garnering metrics so that we can prove efficacy outcome or not, so that we can show that it's translational, high field imaging, a whole host of things. If you just go to an adipose stem cell clinic, my hunch is you just get your stem cells and you're out of there and you're $20,000 in debt. That's kind of my personal opinion. I think that's what's happening.
And I'd say, we both do quite a bit of research in our own clinics and do a lot, do more than anybody else in the state, for example. But with this, where you need inpatient care, bone marrow transplant protocols, academic centers best geared to do that kind of a research.
I have one quick question. What is the likelihood that remitting, relapsing MS can develop into progressive MS?
Okay, that's a very good question. And we have really natural history statistics. Before we had treatments available, a good 50% of people, maybe 12 years from the onset of relapsing remitting would enter into secondary progressive, and some studies are a little bit variable in their percentages. Some say up to 85% at 25 years will have secondary progressive disease. That's untreated. We see a very, very different picture these days. So these days, we've seen quite a number, 15 years, relapsing remitting, haven't budged, no hide nor hair of secondary progressive disease. What we're seeing maybe more commonly are people who had a pretty vigorous attack, maybe paralysis on one side, improved, and then maybe 10, 12 years later, it starts to weaken. And because the pathway frays a little bit more and more and more, and you have less juice to be able to connect down to the muscles, and then they become weaker. But unlike my mom's case, where what happened this year would be reflected 8 to 10 years later, so she'd lose function of her legs, then the next year's attack would wear out. 8 to 10 years later, she'd lose bowel and bladder control, then use cognitive function, then arm function, become bed confined and die. That's classic secondary progressive, kind of the slinky effect. Happens here, worsens 8 years later. What happens next year worsens. That was what we knew of secondary progressive disease. Now we're seeing limited secondary progressive disease. Our agents have been very good in secondary progressive disease, not to stop the wearing out of what's already happened, but new lesions. And if you stop new lesions, they can't wear out. And so we see a worsening of the original deficit, but then a plateau. And we're not seeing additional things become secondarily affected.
Okay, new question over here. I'd like for you to, it's difficult for you both to answer questions because we're just getting so many people right now that want to ask. So maybe we could just alternate back and forth, all right? Unless you have that much more to add to it.
Okay, I saw a commercial on TV, and they were saying, is your Social Security enough for you to be able to help with your medical cost? And I automatically thought, let me call them up, because I wanted to know, because when I fill my, I take ADD medicine, and when I fill it each time, it gets bigger and bigger as far as how much it costs. And he goes, the guy that I was talking to goes, well, I think you need help with this because it says right here that you get help. So I guess I'm just a little confused. I didn't know whether or not I should take it or not. He said, are you ready to make this commitment? And I'm like, no, I want to talk to my doctor first. So I didn't do it. But I was just wondering what you think about that when you see these commercials, when they say, you know, it was Humana Gold was the one that they wanted me to do. So I don't know, is this like my insurance I would be doing?
I recognize that voice. I recognize that voice. Okay, so I mean, there's several things embedded in this question, but I mean, the first issue is the commercials. Beware of commercials, right? We don't roll that way. Those are there to try to get you to buy into something that you may or may not need. Insofar as Social Security, Medicare, drug policy, you know, there have been a lot of changes in that landscape over the past several years. But if you're on disability, you know, you'll have a drug benefit, and you have to sign up for those things in October, you know, of every year. You have till January to solidify that. But, you know, as we know, we're kind of handcuffed, Dr. LaGanke and I, because we have our ideas about what we think might be the best, but, you know, the government and the commercial insurance companies have their ideas. So, but we're going to stay after them. You know, just become an advocate for yourself. Those of you that are caregivers, become an advocate for your loved one. And just keep on keeping on.
Next question's on the other side of the room.
Hello. The hereditary question in the beginning, as Dr. LaGanke knows, I have a brother that was just diagnosed, and I was diagnosed 3 years ago. We're from the north, and your studies on those twins said from Canada. Environmental type things, you know, I went back to my family and said, has anybody ever been diagnosed with MS? And to their knowledge, no, but then again, all of this is new, and most of those people have become deceased, but they had different conditions like I have. And so being further away from the equator, but we had moved to Florida when I was 14. I'm almost 58, and I've been in Alabama for 14 years. So I was in South Florida for 29 years with the sun and everything else. So environmental, and with our children, with the first question, is it a good time to have them pre-tested somewhere if they're like showing some of our symptoms, or on a physical, just mention it to their doctor so that they can do something to see if it might be something that they should be concerned with in the future?
Yeah, so that's also several ideas embedded in that question. I get that question a lot. Should the children be tested if I have a diagnosis, if it's in the family? And Emily may have a different answer, but mine is typically, you know, don't fret and preoccupy yourself with coming, you know, as far as a child or a family member, with coming down with a condition. And there's really not good data at this point to say there's any good screening system in an asymptomatic patient. So, and people are different. Some are worriers, some are not. And so our advice may be different for the worrier than it is for others. We don't want people to come to the doctor every time they have a stub toe and numbness here lasting X amount of minutes. And yet we don't want people to blow off symptoms that may have been a sign where we could treat them very early. So we have that balance of informing the offspring age dependent, informing them that you do have a little increased risk of developing this condition. Not likely, your odds are very good of not developing this condition, but should you have some kind of numbness, visual problem, neurological issue, probably better not to blow it off and to go and seek care, because we know treatments work so well, are so much better when we implore them early. Okay. I guess the other part of that question is there is a difference in latitude. So the further away from the equator, the higher the incidence. Of course, with mobile societies now, that's changing. The age was 15 before. If you move before 15 or 16 to an area of high risk, you adopt the high risk. If you move after 16, you retain the risk from where you came. I think that had to do with puberty back then, because that was many decades ago. So it might be 12 or 13 now if we looked at that data. But that's real interesting data. Is vitamin D, environmental, genetic. People from Northern Europe like to live in colder areas, so maybe it didn't have anything to do with the latitude, but just where people were comfortable in living. So very complex as far as that goes. Mm-hmm.
I agree with Chris insofar as the children are concerned. I pretty much, tell the individual that has MS, the child that has half of their mother or father's genes too, right? And the incidence, as Chris said, is so low that we don't advocate, sending them for MRI imaging or anything like that. But I do want to say for cases that, for example, say someone develops synoptic neuritis or a transverse myelitis or something that's real, we do have a pediatric center at UAB, and the medical director of that is Dr. Jane Ness, and it's one of 6 pediatric centers in the United States. So we are very fortunate here in Alabama to have one of those centers, and it's called CPOD.
Question over here.
My question is about the monoclonal antibodies. If a patient has been allergic to one monoclonal antibody, are they then going to be allergic to all the new monoclonal antibodies that are coming out?
No, I mean, not necessarily, no. And we have a way too, depends on what this allergy is. There's anaphylaxis, which is something real, where you can have neutralizing antibodies developed specifically to a monoclonal. And we know that from our Tysabri data, and I've seen that before, and I'm sure you have as well. But no, we can make switches to other monoclonals because they're different. But there's anaphylaxis, which is rare, and then there's all this kind of anaphylactoid, which is kind of all this, well, I'm kind of feeling itchy, I kind of feel dizzy, I kind of feel this, I kind of feel that. Those things don't scare us. We basically just circle back around and pre-medicate with, antihistamines, Tylenol, steroids, whatever we have to do to make that happen. Because at the end of the day, we're trying to suppress that inflammatory response that's causing the inflammation and the secondary axonal degeneration.
Yeah, I mean, there's cytokine release syndromes and histamine release syndromes that are different than anaphylaxis, but they make a person feel real bad. But as Emily said, we're very different. The approach to those are very different. The anaphylactoid reaction will not treat with them, that monoclonal antibody again, but we'll pre-medicate the other ones. And some people have allergies to lots of different treatments, so maybe their risk is a little higher if they had an allergy to one monoclonal, but by itself, having an allergy to one does not indicate you're going to have allergic reaction or a likelihood to another one.
All right, we only have 10 minutes left of questions, so.
I just wondered, for all the population and the statistics that are given about the age, race, that are given of who is at risk of getting it, do those change over time? Have you seen that this population, more children are now being diagnosed, or more women or men, or?
Yeah, that's an awful statistic collecting that we have at the present time. We're still quoting the same numbers from 1990. 400,000 people in the U.S. with MS. One person is diagnosed every hour. We know one person isn't dying every hour, so the math in the last 26 years is certainly going to favor there being a lot more, but there's no real good data collected. We still use those same numbers, and worldwide the same. There are certain registries in like Denmark and other countries where they capture every single person almost to the T, where you have to register, where they're getting good statistical analysis. But we don't have that globally. There's something called MS Base, which is trying to have everybody register so we have a better idea of the statistics, which really helps funding. I mean, it helps funding for all of you. If we had more numbers, we have the same numbers as 1990, we're not getting better funding because the numbers still stay down here. So it really behooves us to have more accurate numbers to collect that. But yes, the statistics are definitely changing, increasing incidence, but we don't have real good numbers to say how much.
The pediatric MS, I suppose, was always there. It was just underestimated or underappreciated because we didn't have MRI imaging back in the day. And so the child was just described as being clumsy or what have you, or functional. But I do want to put in one plug for NARCOMS, which is through the consortium. It's a registry, international registry. It's housed here in Birmingham at the University of Alabama at the School of Public Health. Gary Cutter and those guys are very involved with that. So if you're not registered with NARCOMS, go online and just become a part of that database, because it's going to be huge going forward. And I would like to say, and Chris would as well, that Alabama has 100% compliance with data registry. There's no reason why we shouldn't. It's one of our initiatives, and I would really, really encourage all of you to do that.
So I just want to go back to the secondary progressive question again. At what point, I understand that when you're treated, your occurrence is low, but when you're being treated and the treatments aren't working and you're going from medication to medication to medication, at what point do your symptoms start worsening and not getting better, but there's no changes on your MRI? Do you start looking at that diagnosis?
Sure. So that, secondary progressive is technically diagnosed as a sustained worsening on the neurological exam for 6 months. So you have the same or worse deficit 6 months in the absence of any relapse and the absence of any active disease that one can see. So that's the technical definition of secondary progressive MS. So if you're worsening, old symptoms worsening despite treatment, that would support secondary progressive disease. You have to look for other complicating factors, but that supports that. Now, we have a real problem politically with secondary progressive disease, because when you're diagnosed with secondary progressive disease and not having relapses, then you're cut off from treatments. And that's misguided. None of our medicines stop the fraying of a damaged area. We don't expect them to do that. But what they do is they stop new lesions. So what the trend is, someone's ravaged enough to get into a wheelchair with secondary progressive MS, still has arm function, cognitive function, and they want to take away the medications because they're secondary progressive. But don't those individuals more than anybody deserve a medication to stop new lesions, to preserve their arm function and their cognitive function? So it's not going to stop the fraying of old things. So we would love to do that, and we're working, as Emily said, in some medications to try to help that. But taking medications away because someone's progressing with an old deficit is the wrong answer at this point, in my opinion.
Is there a lot of research being done on like the environmental factor that causes MS, and like what is it focused on, if there is, and where is it being done?
Yeah, research is being done worldwide, looking at everything. I think one of the interesting topics right now is this whole notion of why do women go into remission during pregnancy? That's a fascinating concept to me. So there are people looking at estriol, hormones, vitamin D, dietary issues, monoclonal antibodies, stem cells, you name it, it's being done. But what we need is money. Okay, the NIH has, they just don't have the same funding that they used to. The CDMRP, which is a defense budget, just doesn't have the same coffers that it used to have. The society does a lot of funding of MS research, but you can go to clinicaltrials.gov, the website, and it'll give you a list of every trial that's being conducted right now, and tell you where those trials are being done. It's interesting just to go there and to see, and it'll answer your questions insofar as some of these environmental trials.
And if I can just follow up quickly on that one, it's probably not that there's one cause in everybody. And that's the complex thing. Epstein-Barr virus may be important in quite a number of people. That's a triggering virus that sets things in motion. But you can see people who are Epstein-Barr virus negative and still develop MS. And you can find exceptions for any of the causes we've really looked at. So it probably has to do with the multitude of genes that are involved, and let's say you have a gene profile A, well then you're susceptible to MS if you are exposed to this virus, that bacteria, this, and Johnny over here has profile B, and the things that trigger your MS don't trigger his MS, and the things that trigger his MS don't trigger your MS. So it's a very complex thing when we look at cause, and we're getting closer, but I think really if we find genes, better genes that are involved in this, we'll see why why the susceptibility is as it is. And females have a much higher incidence of autoimmune disease anyway. So maybe the hormones allow a wobbly or sloppy immune interpretation of self versus the foreign, the outside world, and that's why we have a higher incidence. So it's multifaceted. We're extremely interested in it, and as Emily said, we really need good funding to explore these thoughts.
Yes.
Oh, hi. With Lemtrada, my understanding is, okay, it's been here for, I guess you said 5 years, but isn't it also in the rest of the world, Europe and Canada and Latin America? I'm wondering, what is the longer view of it? What's coming out of these countries where I'm assuming they've been using it longer?
Okay, so Lemtrada was approved in Europe about a year plus before it was approved in the United States. We were involved in the clinical trials that led ultimately to the approval. So we have 16 patients been on it 6 years, or entered the trial about 6 years ago. So we have that experience, and other centers who are in the trials have that experience. It was really founded in England, in Cambridge, and I was given a lecture in Berlin, and the person who first used it was there as well, and has 87 patients now that are 18 years out, doing well as a total group. But there's not a huge number of patients that have been on it a long time. About 1,000 patients were in those 3 clinical studies that are moving forward, and 90% of them are allowing us to continue to evaluate them and see how things are going. So we're going to have better and better data. I'm going to present at the American Academy meeting in Washington next month the 5-year results of those cumulative trial experience. And so we're going to continue to kind of broadcast that so everyone has a knowledge of not only benefits but also risks. Did things emerge that we need to be aware of over time? So it's really, and kudos to those in the trials who are willing to give us these answers. We wouldn't have these medications available if people were not willing to participate in these trials with medicines that we don't know exactly what's going to happen.
Yes, I have a question that goes back to genetics. Do you know of any research that's being done in the genetic field that can be used to possibly predict the probability of an individual developing MS, and that data being used that could help develop some type of forms of treatment to prevent the development of MS?
Absolutely. The genomic research, started in Stanford, and believe it or not, many of those people have migrated to Huntsville, Alabama, where they're conducting high-field research on a whole host of autoimmune diseases. So, yes, that work is definitely being done.
Good morning. Good afternoon. With the people that's on Lemtrada, you said after a couple of years they didn't have any more lesions. Wouldn't that be better and cheaper than stem cell procedure?
So the question is, patients on Lemtrada who are doing real well after a few years, is that not a better option than stem cell? And it's a different option. So yes, patients are improving, and some still improving 3-4 years later. The level of improvement is, on average, small, I would say. There were the percentages that I gave you that were 2 points, 1.5 points better, 10% or less in each of those categories. So I look at this medication more as a possible cure in some people, as far as you take this medicine, you don't have to take anything again, and you're not going to have any more problems with MS. But it's not a fix. So same like breast cancer, woman has a breast removed because of cancer, gets treatment. 5 years later, the oncologist does a happy dance, says you're cured of the cancer. It doesn't bring the breast back. So it doesn't bring, in this instance, the neurological function all the way back. So it's more changing the system so your susceptibility for more disease is controlled. But things like anti-lingo and stem cells are more to fix and repair and restore function. So because if you fix with stem cells and with anti-lingo, that doesn't necessarily keep you protected from more things happening down the road. It's more for repairing what's already been damaged. It's not necessarily protective. And I look at Lemtrada more as very protective, and those agents as fixative. So curative and fixative, in the ideal world. And time will tell us how well Lemtrada does over years.
Okay, I'm going to let you all know that we're doing just one more question from that side of the room, one more from this side of the room. If anybody has questions, and there's probably a lot of them, that were not being able to be asked, you could send an email to me, and I will then send it to these two doctors for them to answer directly to you. I don't want to get in the middle of that, all right? So they're going to have to answer it directly to you by email or however they want, smoke signal, something, all right? But, and then we're already talking about it, just so you know, that we hope to be back in a few months from now with only to do a Q&A with these two guys up at the top, all right? So we hope to see you all back for that. Talk to you later, though.
Okay. Can you tell me the status with Blue Cross Blue Shield and Lemtrada?
Well, okay. Yeah, we actually know a little bit about this. Dr. LaGanke and I both serve on the Clinical Advisory Committee of the National MS Society. We both have comprehensive MS care centers, where we engage in infusion therapy. The biologics have really gotten Blue Cross Blue Shield's attention over the past several years because of the cost, okay? So they have implemented these things called step edits, whereby they ask us to try one or two other things before we give you Lemtrada or Tysabri. In our personal view of this is that's really not appropriate, because the time to treat MS is at time point 0. That's the time to really get this disease under control. So as it turns out, the folks at Blue Cross, lovely people, wonderful people, PharmDs, medical doctors, an advisory panel, they just don't know a whole lot about this. And Dr. LaGanke was out recently championing this with this group of individuals, and I received an email on Friday saying that they want some representatives from our group, Dr. LaGanke, myself, Dr. Rinker, to join hands with them to come up with an effective policy so that we can have our green light to give you what you need when you need it. And I'm confident that this is going to happen. Would you like to comment on that?
So I personally met with Blue Cross 4 weeks ago, 7 lovely ladies. We planned on an hour. It ended up being 3.5-hour long meeting. And it was a very positive, informative meeting for Blue Cross Blue Shield. And a week later, they instituted a new policy on Lemtrada, because prior to that it was very difficult to get it approved. They didn't really understand the medication, the reason for using it, because it's a very new medication. So that took a bit of education, and they have a much kinder stance on the medication right now, and they want to explore that further and get the expert's opinion on when to use that medication, when it's appropriate. The FDA comes out with a recommendation that it's generally or it's reserved for people who generally have had an inadequate response to 2 other medications. That's the verbiage in the label. And the FDA, I've been in contact with them twice in the last 2 weeks to get them to further define what an inadequate response is. Because I think that someone who's on Tysabri and has a positive JC virus and has had many, many infusions, that's becoming an inadequate response because the risk is going up, the benefit's staying the same, and so that person should be afforded an opportunity of a medication that may not have that risk with it. And they didn't see that as they were looking at clinical inadequate response. They were getting worse on their Tysabri, and Tysabri is very effective, so a lot of people don't get worse. But they're having this increasing risk based on the virus, the presence of the virus. And so the FDA answered me and said, we think this is a very individual response, Dr. Riser, myself, and you all, to have that discussion, and it should not be an impediment to go on this treatment. For whatever reason, we think that the current treatment is inadequate or unsafe. So that they kind of echoed that without specifically telling insurance companies what they need to do. They walk that fine line of trying to give us as clinicians opportunity to do what we think is best for the patient without telling insurance companies they need to do this or that. Now that's where we're sitting now. It's an ongoing process. It's much better, I can tell you today, than it was 4 weeks ago. Much better. No, they're not the only insurance carrier. They affect 85% of lives in the state of Alabama, so they're pretty dominant here, so most patients go through that avenue. But yes, other carriers as well had to figure out this. Some are easier to the start, and others are slower, but yep.
One last question over here, please.
Yes, hey, Dr. Emily, you had mentioned the anti-lingo 1 and a trial that you were doing, Dr. LaGanke, and I wanted to know more about that.
Yeah, I'm going to let Dr. LaGanke answer that question. I know that voice too.
So this is a monoclonal antibody, as Emily talked about, that's in this study used monthly. It's an IV infusion given monthly for 18 months, or it's an 18-month trial, so at least 16 months of monthly treatments, IV treatments with this monoclonal antibody, 4 different doses of the medication and a placebo. And they're also on a platform medication. They're on Avonex as their daily medication to keep, or their weekly medication to prevent the disease from getting worse. And then the anti-lingo is designed to look at what kind of repair we have. So it's a blinded study. We don't know who's getting what. We had one patient who came in and could barely walk 20 meters with a walker, which was the minimum criteria to get into the study. And within a few months, he's driving independently, he isn't using any device. It could be placebo. It could be the low dose, the high dose. I have no idea at this point what anybody is getting. We will. The study should be done in the next 6 to 8 months. It's a worldwide study, and hopefully we'll get very positive results on which of the doses are the best to move forward.
All right. So thank you, everybody, for the Q&A.
Thank you.
Now we're going to go on to the next portion of the program. I want to thank Drs. Emily Riser and Chris LaGanke for doing this with us today.